Hello and welcome back. Now we move from L to E in our lesions acronym. The E stands for external, the periphery of the lesion. Honestly, this is usually where I start when I'm describing a lesion. In some ways, E is even more important than L because it's the first thing your eye does. You ask, is this well-defined or is it ill-defined? So here's the simple test. If you could take a pencil and confidently outline the border of the lesion, then it's well-defined. Or since I'll give you a little leeway, if you could outline it with a fat crayon. So instead of a small pencil, think fat crayon. I'll still call it well-defined. And this is what I mean by it. Look at these two lesions. You see how it has nice, sharply defined margins? In some areas, it may look a little more blended, but if we can outline that with kind of a fat pencil or fat crayon, then I will still call it well-defined. Specifically, if you see parts of the lesions that are definitively corticated, I'm going to go to well-defined rather than ill-defined. And so this lesion is very well-defined as opposed to down here. Where are the borders of this lesion? Does it end right there? Does it end way out here? Can you outline it with a fat crayon, kind of going back and forth and irregular? You might argue that it's there. Someone else might argue it goes all the way to here. And so that's the very definition of ill-defined. But why does this matter? Well, because the border tells you about the behavior. A well-defined lesion is slow growing. The bone has time to react, to lay down new bone, to lay down a cortex, to wall off the lesion, and those tend to be benign, a cyst or a benign tumor. Whereas an ill-defined lesion tends to be growing fast. The bone hasn't had time to react to lay down that cortical border, and so those tend to be malignant or sometimes an aggressive inflammatory process. So it means a lot. Same idea, different illustration. Here we see this lesion around the crown of this tooth is very well defined. It's even corticated. And so what do I mean by corticated? That's this thin radiopaque or white line that you see around this lesion. And so when it has that, you know it's a very well-defined, a very benign type of lesion. And this one is likely a dentigerous cyst again, which we talked about in the last video. And so well-defined can be corticated or it can be non-corticated. Here in these multifocal lesions, we see these round, very well-defined lesions, but most of them don't have a corticated border on them. And so this specific presentation, when you have these small round lesions, is more specific, and you can describe that as punched out. And that's specific to something called multiple myeloma, which we'll talk about later. Although you may also think things like Langerhans cell histiocytosis, metastases of a different primary lesion. But for now, let's just focus on the description. Punched out is well-defined, non-corticated. You may have solitary lesions that are also well-defined and non-corticated. This is just the example that I give you here. Another term we use to describe the periphery is sclerotic. And sclerotic you can think of as similar to corticated. When I tend to use sclerotic, it's when there's more of a thick corticated border, kind of thick sclerotic border around it. Or you may use that to describe the bone around it. If the bone is reacting to something like infection, then, as we see down here, the bone tends to become very radiopaque, very sclerotic. And so those are the cases in which we'd use this term. So think of slow growing, again, with significant stimulation of bone formation. And as I just described with the sclerotic or reactive bone around it, that makes me think of an inflammatory, chronic stage of an infection. A lot of times periapical inflammatory lesions have chronic sclerotic bone around it. And in the case of these chronic inflammatory lesions, the sclerotic bone is actually the body reacting to the infection and trying to wall off the infection. That's why you get those sclerotic borders. You may hear the term lytic in contrast to sclerotic. Lytic just means resorbing. So when the inflammatory products are kind of eating away the bone, that's resorptive and it's more radiolucent than it is radiopaque. All right, what about when a lesion has a radiolucent rim? Usually we use that with a more radiopaque lesion. And so you can see this nice, well-defined, thin radiolucent rim. In this case, you can see a little bit thicker, varying thickness of radiolucent rim in that case. And that's a very specific descriptor. And so there's a paper that identifies 8 different lesions that present with a radiolucent rim. There are 3 types of osseous dysplasia. There's also ossifying fibroma, osteoid osteoma, osteoblastoma, odontoma, and cementoblastoma. The 2 examples in this case, this is an odontoma, and this is a cementoblastoma. And I'll do a whole segment on these lesions, the radiopacities with radiolucent rims, And I come up with acronyms for each of the differentials. For this one, it's CO5, because if you pay attention, I named one thing with a C, that's the cementoblastoma, and all the other things in this group start with an O. So it does help you memorize what those lesions are. All right, now on to ill-defined. So there's two different flavors of ill-defined. There's blending and there's invasive. Blending means more of a gradual transition. Here we see blending from this more sclerotic radiopaque bone to where it's more normal marrow space. And so that's kind of the more common ill-defined presentation. Here we see a case where it's kind of a granular radiopaque appearance, but where does it end and normal bone begin? Here we start to see more normal marrow space. And so blending doesn't always mean malignant. Ill-defined doesn't always mean malignant. It just tends to occur more in malignant processes or aggressive inflammatory than with benign things. So in the case of inflammatory, this is a diffusion of inflammatory cytokines that causes this reaction in the bone. Sclerosing osteitis is what we call when it's a periapical inflammatory lesion and it appears opaque. But even things like fibrous dysplasia, which we see in this case, that can have a blending or ill-defined border. Then what do we mean by invasive? And so that's a little bit different. If you see few or no trabeculation on the border, the lesion is moving through the marrow space, creating finger-like projections of bony destruction. This is rapid growth, and in most cases, this is going to be malignant. So when it's purely radiolucent and ill-defined, usually that's going to be malignant. In some cases, you can have an aggressive inflammation that causes that same type of bony destruction. But in this case, both of these have arisen from a malignancy, likely from a squamous cell carcinoma. All right, this one I really like for invasive. Look at the way it's kind of extending into the marrow spaces, kind of widening those marrow spaces, almost like finger-like projections, projecting into the bone. For the fantasy fans out there, if you're familiar with The Wheel of Time, this looks like the mists of darkness, so something very foreboding. And the appearance just looks overall dangerous to me. So when you see something like this, when it's really narrowing marrow spaces, really think malignancy. Often it's a hematopoietic malignancy. This is a lymphoma in an older patient. But just for now, recognize the sign, recognize and be able to describe this as ill-defined. And you might go as far as to describe it as invasive. All right, I'm going to give you a chance to practice. Maybe you'll remember this one, but let's just talk about describing the periphery of these lesions. What did we say right here? Is this well-defined or ill-defined? So start with that when you're thinking periphery. This one is multifocal, so if we go back to location, but the periphery of each of these lesions is very well-defined. In some cases it appears a little bit corticated, but most of them appear non-corticated. And what was the more specific term we used for this? This appears punched out. It looks like hole punches taken out of a piece of paper. And this was multiple myeloma, which we'll talk about more later. All right, what about this one? Is this well-defined or ill-defined? Well, in some regions of it, it looks a little ill-defined, but other areas it looks definitively well-defined and even corticated. And so if you see any part of that, that's not just some adjacent anatomical structure, sometimes you'll see it aligned by the canal, you'll see it aligned by the sinus borders, and that appears corticated. That doesn't mean the lesion is causing that, so be aware of that. But this is not an anatomical structure, this is a border of the lesion, and it's corticated. So this is very well defined, more likely going to be a benign lesion, even if parts of it tend to lose that well-defined border because of adjacent infection. It communicates with the oral cavity. Anything can become affected, and then that tends to resorb those corticated borders. But this is what I would describe as a well-defined corticated lesion. And so that's a teaching point I want to reiterate one more time. Any lesion, when it communicates with the oral cavity or the external environment, it can become infected, and that infection can start to resorb those nice, well-defined corticated borders. So be aware of that. This one just happens to be a residual cyst or a periapical cyst when this molar was extracted, but the cyst remained and that cyst continued to grow. That's what we call a residual cyst. All right, so that's it for borders. So well-defined versus ill-defined first, then get more specific. Is it corticated, non-corticated? Is it sclerotic? Does it have a radiolucent rim? Is it blending? Is it more invasive? So each of those terms points you toward a differential or a different bucket of lesions. In the next visit, we're going to cover shape, size, and internal structure. So the two S's and the I of lesions. See you on that one. Thanks. Bye.